Thank you for those kind words. Thank you, madam, for having me here. Thank you all the audience. And it is very difficult to, you know, talk about the IVF protocol. But it's a whole day session, but it's difficult to cover in 30 minutes. But we will touch upon the. I do not want to go into the too much depth of the protocol, but I want to touch upon the philosophy and how the thought process can help us in taking decision. So before deciding any IVF protocol, we must understand what is the rationale of the ideal protocol. So there will be proper down regulation, LH window should be maintained, there should be maximum follicle output rate, maybe in the tune of 80%. There should be not only a follicle output rate, FOI, oocyte ratio should be also be somewhere around 60-70%. There should be a minimize progesterone per follicle ratio, because that is the ultimate importance. If the follicle progesterone per follicle is high, that creates a lot of problem, changes the endometrial receptivity. There should be coordinated oocyte, cytoplasmic and nuclear maturity. There should be OHSS free protocol, and there should not be any premature LS surge or progesterone elevation, and should not affect the endometrial receptivity. So these are the, in general, the goals of the IVF stimulation. So what factors you must consider before selecting the IVF protocol? You must understand what is the indication, why you are doing IVF, what's the indication, whether it is endometriosis, PCOS, whether it is fertility preservation, for what purpose you are doing. Second, you have to assign the patient into the responder group, whether they fall into a low responder, normal responder or hyper responder, because protocol doses, everything changes with the responder group. Then you must understand what is your aim. Are you going to freeze all, what is your policy, or you want to take a balanced decision, or you want to take a freeze all cycle, or you want have preference to transfer fresh, because everything is going to change the protocol, which we are going to discuss in next couple of minutes. And you must, if you have any history of previous stimulation at somewhere else, then you must know what is the dose and what was the response, and what happened and what trigger was given, and how many number of mature oocytes. All those details you must have. And whether are you going to include the emergency patient. Now, because this is very common, the patient is on 5 days pills coming to you, she wants to do IVF. The patient who has got, say, 8 days of the cycle, she wants IVF to be done immediately. So they do not want to wait for some reason. Either they have come from abroad, or they have a limited span of time for this purpose, whatever reason. So you must decide whether you want to include in emergency any IVF patient or not. So broadly, if we decide the protocol which is based on the onset of gonadotropin stimulation, it's a standard follicular. We start gonadotropin just after the period, then the luteal stimulation, dual stimulation where follicular as well as the luteal stimulation we do, and the fourth is a random start protocol. At any given point of time, the IVF stimulation can be started, because there are multiple follicular waves, and ovaries are always ready, and some follicles are always ready to recruit any point of time. If you divide the protocol based on mode of down regulation, because why you want to down regulate the pituitary? Because you do not want premature LS surge. So based on the mode of down regulation, first is the antagonist protocol, second is agonist protocol. In agonist protocol, there are long agonists, ultra long, short, ultra short, mini flare, ultra short mini flare, interrupted microflare. A lot of variations are there. And there is a mixed agonist and antagonist protocol. There is a progesterone prime protocol, which nowadays a lot of people using very commonly. And last is CC. This is one of my favorite protocol, especially in donor. So this is because when you give CC, the earliest surge of LS surge, which can happen not before 4 days of stopping the CC, clomiphene citrate. That's one wonderful thing about the CC. And second thing, when you are giving CC, there is always a good level of LH, not only FSH. The LH is secreted from the pituitary, so which helps in symmetrical follicular cohort. So we use CC very commonly in when we are stimulating the donor. Not only reduces the dose of the gonadotropin, but it gives a symmetrical cohort. It prevents the LS surge, and the follicle, the protocol becomes very economical. Now, if you divide the protocol based on the quantum of stimulation, it's a standard stimulation where you aim for maybe more than 13, 14 eggs. There is a natural cycle, then you don't give anything. Modified natural cycle, you give trigger. In mild stimulation protocol, you use oral ovulogens and reduce the dose of the gonadotropin. Your aim is somewhere around getting 6 to 10 oocytes. And minimal stimulation of protocol where only trigger and antagonist and some 1 or 2 dose of gonadotropin is used, and no other drugs are used, where you aim 2 to 3 or 4 oocytes. So based on the requirement, these protocols are divided. So briefly about the agonist action. We all know there is an initial flare which lasts for 3 to 6 days, and then there is a down regulation. Down regulation may last for 9 days up to 6 weeks. Agonist has got very high affinity and can easily replace the antagonist, and that's how we give agonist trigger in antagonist protocol. The one thing about the agonist is agonist has got direct positive stimulatory action on the ovarian follicle granulosa cells. That's why when suppose we are giving in any protocol agonist plus gonadotropin, if we stop both, there is a fall in E2. But if we continue agonist and we stop gonadotropin, still there is no fall of the E2, and E2 keep rising or maintain the level. That itself proves that gonadotropin has got direct action, stimulatory action on the granulosa cells. So there is initial flare. Whenever you are using any low-pride depot, never manipulate the cycle, never do anything before 14 days. Because the FSH and LH level will bring down within maybe 1 week. But estrogen and progesterone will take 14 days time. So never stimulate when you are using depot, never stimulate before 14 days of agonist injection. So agonist depot injection can be given on second day of the period, wait for 14 days, confirm the down regulation and start stimulation. There is no problem. The only problem with this is there are chances of cyst formation because there is an initial flare, and this cyst keep disturbing you. Although after 14 days, if you measure, even if in the presence of cyst, if you measure the E2 and LH level, it is always down regulated, but still that creates a disturbance in your mind. So this is a standard long agonist protocol where luteal, mid-luteal agonist is given on day 21, and then after menses the normally agonist dose is halved or reduced, and then the gonadotropin is started. Always SCG trigger when we use agonist protocol. Now what are the criteria of down regulation? Quickly, E2 it should be less than 30 picogram, but if it is antagonist protocol, even up to 75 is okay, because there is no pituitary down regulation at the beginning of the cycle. The LS should be less than 2 international unit. If it is antagonist, up to 8 is okay. P4 should be less than 1.2 nanogram. There should not be any follicle larger than 10 millimeter, and endometrial thickness should be less than 5 millimeter. So, if you really know the physiology well, you can manipulate everything. Whatever happens, you can manipulate. Suppose E2 is high, you can always give antagonist and or continue agonist and wait for some days. Suppose there is a rise, basal LH level is high. That quite often happens in the PCOS. You antagonist or you start progesterone, then bring down the LH. So you can manipulate. If you have basic knowledge of endocrinology, you can manipulate the cycle the way you want. The P4 is less than 1.2. Now P4 is really difficult to manage because early follicular P4 secretion, you never know, it may be adrenal origin or maybe rescue corpus luteal cyst. You do not know. We can give antagonists which will bring down the progesterone level, but ultimately when you measure the progesterone on the day of trigger, it is always raised. It is high. So there is no a perfect solution for early follicular progesterone elevation. Now benefit of long protocol, The main benefit of long protocol is it takes care of asymmetry of the follicle. When you start stimulation, you get a plain ground. No estrogen, progesterone, androgens are elevated. That's another advantage. The third advantage of you can afford to have costing. You can afford to have 1 or 2 days delay in the trigger. You can, I mean, that is absorbed well, which is not absorbed well by the antagonist cycle. So costing, the batching is more easier. So these are the salient features of the, benefits of the long protocol. And as I said, agonist has got direct action on the follicle. The peak E2 and endometrial thickness is better. Now, lot of studies have come, lot of conclusions have come, but you show me a paper which says that antagonist protocol is better than agonist protocol, long agonist protocol, or long agonist protocol is inferior to antagonist protocol. Everybody will talk about the chances of OHSS, but as far as the results are concerned, as far as the peak E2 is concerned, as far as the endometrial thickness is concerned, the agonist protocol, long agonist protocol is the best protocol, minus you have to be careful about the OHSS because you cannot use agonist trigger. There are certain drawbacks. One is chances of OHS because you cannot use agonist trigger, and second, there may be, it's a long protocol, the uses of gonadotropin increase maybe by, I would say, 700, 800 units of gonadotropin are used more. The stimulation is lasting 1 or 2 days at least more. So if you are ready for this, it's fine. This is a diagrammatic representation. Then what about the antagonist administration? Antagonist is very popular protocol amongst the all youngster because they just understand when to start antagonist, start stimulation, when to start antagonist, and then matter ends. But it is not that simple as it looks, because there are certain problems which we are going to discuss. So how is the antagonist action? The quick reversible suppression of the pituitary which happens in 8 hours. The effect is more on LH. The half-life is 20 hours. So you need to repeat at least every 24 hours. Cetrolix commonly we use. So if the OM pickup is in the morning, it's better to administer antagonist in the morning because there should be at least 8 hours gap between the last antagonist and agonist trigger. So you have to do that like that. There are two protocols, fixed protocol and flexible protocol. If it is a flexible protocol, then when the lead follicle reaches more or equal to 14 millimeter or E2 more than 400 picogram or stimulation day 7, whichever comes earlier in standard antagonist protocol, that is a flexible protocol, and in fixed protocol, stimulation day 6. Nowadays, a lot of studies, they have come up. According to the recent study, the results are better when they started late, when E2 level is between 500 and 1000 picogram. The late start when mild protocol or when CC is used. If the protocol is mild, where lower dose of gonadotropin is used, or the oral ovulation in the form of clomiphene is used, you can afford to delay antagonist administration even up to 16 millimeter when the size of the follicle reaches up to 16 millimeter. This is about the antagonist administration. Minimum 8 hours and maximum 20 hours gap between the antagonist and agonist trigger. The advantage of the antagonist protocol is single most is the OHS prevention and less consumption of the gonadotropin. These are the two very, very important advantages of antagonist protocol. The agonist trigger can be used with all its advantages, and if you notice, all the soft protocol or mild protocol are possible only with the antagonist protocol. It's not possible with the agonist protocol. And antagonist has got direct action on the lutein cell, reducing the VEGF, which helps in reduction in the OHSS. So what are the drawbacks of the antagonist protocol? The biggest drawback is the asymmetry of the follicle. That's the biggest problem. The batching is really difficult as compared to the long agonist protocol. Antagonist affects the endometrial receptivity. It has got negative effect. The unrecognized, you don't get plain ground when you start stimulation. There may be progesterone elevated, maybe estrogen elevated, maybe, see, if unrecognized estrogen is elevated, your results are going to be disturbed. If FSH, unrecognized FSH at the beginning of the antagonist cycle is more than 9, then your results are going to be affected. So we are not measuring, at least in my center, I do not measure all the time all the basal levels and all those things, because sometimes it is, if wrong reports, it's more confusing and more creating anxiety. But then if it is unrecognized, then sometimes problem can be there. And the batching is another problem which we already discussed. There is no universal acceptance or consensus, you can say, when to start the antagonist protocol. Because earlier we all used to believe, please listen carefully, we all used to believe that when there is a rise of estradiol beyond 200 and that sustains for some hours, maybe 50 hours, then the LS surge is initiated. This is old thinking. This is old thinking. Newer concept is, it's not estradiol. Estrogen primed follicle, when progesterone is elevated, that initiates the trigger. Not the estradiol is initiating the trigger. The progesterone which is coming from follicle, when the oocyte is ready to liberate or ready to convert into M2, mature oocytes, near mature oocytes, that gives a signal. So the progesterone is secreted and that initiates, that changes the pulsability of the GnRH, and that's how the LS surge happens. So ideally you should not worry about the LS surge if the follicle size is less than 15-16 millimeter, because we all know after 15 millimeter there are chances of getting mature oocytes and ovulation. So till 15 millimeter I think you should not worry, and especially when you are using oral ovulation, you are protected because next 4 days the LS surge is not going to happen. The drawback of antagonist is costing is not possible. So if you do costing, then you have to freeze the cycle. Chances of premature LS surge is higher as compared to long agonist. Early follicular progesterone elevation is difficult, to manage. There sometimes estradiol level may plateau or fall after antagonist is started. It's different. Sometimes it is elevated, sometimes it is dropped. So it's not clearly understood. Antagonist action is not very clearly understood. So that's many times we are hesitant to use antagonist protocol unless it is hyper responder. SORT agonist protocol very rarely used. The purpose of using SORT agonist protocol is you initially you want flare, so which takes help of the natural hormone secreted from the progesterone, which is different from the artificially introduced hormones. So they give a better recruitment. But practically, very few people are using a SORT agonist protocol. Now progesterone. Progesterone inhibits the transmission of E2 signal and decreases the GnRH pulse frequency and increases the amplitude, but net effect is reduction in the LH level. Medroxyprogesterone we commonly use, dose is 4 to 10 milligram. Once you start medroxyprogesterone, the downregulation of the pituitary starts after 5 days and washout period is 5 days. So once you stop progesterone, after 5 days, the pituitary is recovered. To be precisely, after 5 days of washout period, the hormonal level, FSH level, is similar to day 3 of your natural cycle. Right? When progesterone should be started after ovulation, documented ovulation ideally. And if it is OC pills pre-treated cycle, you can start the day 2 also. The usage in long agonist protocol, overlapping 1 or 2, 3 days is sufficient. Many people, they overlap by 5 days, some overlap 3 days, some overlap, even 1 day is also sufficient, because next 5 days you are protected and the flare action only remains for 3 to 6 days. So safety margin is there. In PPOS, it is commonly used. Severe PCOS from the starting along with the gonadotropin is another uses we commonly do. If patient cannot afford to have antagonist right from the beginning and patient is severe PCOS, the AMH level is more than 8, 9, 10, raised basal LH level, severe PCOS, difficult to stimulate, poor responder PCOS, where the progesterone should be, medroxyprogesterone should be started along with the gonadotropin or antagonist. Then the adjuvants regarding the OC pill, it should be started from the second day, always minimum 15 days for long agonist protocol and 7 to 10 days for agonist flare or antagonist protocol. The prolonged OCP causes profound downregulation, which leads to an increased gonadotropin consumption and agonist trigger failure. the empty follicle. It is the main reason for empty follicle syndrome in donors because they use OC pills like peanuts. Similarly, down regulation starts after 5 days of OC pills. Washout period is 5 days. The overlap is 1 day is sufficient. OC pills are used in all spectrum of the patient, whether you hate, whether you like, but you cannot neglect OC pills. Can be used with the agonist in long down regulated protocol, must with flare protocol to dilute the effect of flare, agonist flare on androgen and progesterone. OCP pills pre-treatment is good. Then the adjuvant estradiol. Commonly, many people have the habit. The estradiol 4 milligram from the mid-luteal phase can be continued up to 18 days, irrespective of the onset of the menses. Even if the menses is there is onset, you can continue with the estradiol. The gonadotropin stimulation to be started after stopping 1 day estradiol free level. If you are starting estradiol in the early follicular phase, the recruitment phase is little widened and you have a better recruitment of the follicle. It increases the sensitivity of the follicle towards FSH. So indirectly it helps. A lot of people can continuing estradiol till trigger along with the gonadotropin. No harm, you can do that. So after stopping estradiol, there is a rebound rise of endogenous FSH which can act together with the exogenous administered gonadotropin. What are addition which you can use in down regulation? You can use, especially young poor responder, luteal E2 antagonist protocol. You can add small activity of the SCG which helps in the maturity of the oocytes. And other expected poor responder, you can add gonadotropin, growth hormone, just 0.5 units. In long agonist down-regulated protocol, if you use growth hormone, just 0.5 units is just sufficient. Testosterone gel in poor responder you can use. Change in the dose of agonist 25%, you can make it 25% of the initial dose. Then the modification of the follicular phase agonist cycle. Nutshell, sometimes in an unexpected poor responder, suppose on stimulation day 7, you want to take a decision whether you want to increase the dose and it is going to be useful or not. So if you measure the serum FSH level and if FSH level is more than 20, that means all the gonadotropin receptors are occupied and there is no point in increasing the dose. But if it is less than 20, then still there is a scope that bioavailability of the gonadotropin is not reaching to the granulosa cell receptor and you can increase the dose of the gonadotropin. Then modification of the antagonist protocol, estradiol we discussed, estradiol with antagonist in luteal into antagonist, small dose of LH can be added, post OCP estradiol can be given. This is another good thing, I tell you. Many times what happens when you are giving OCP pills and after 5 days of washout period, when you start stimulation, one follicle is recruited. So if you do not want that, what you should do, after finishing the OCP pills, estradiol should be continued till the patient gets the menses, because this estradiol will keep check on the FSH and which will prevent the recruitment of the follicle. So that's a very good thing to be implemented in your practice. So this is standard antagonist protocol, nothing much to say. This is basically for poor responder we charted out where we use pyridostigmine also during the follicular phase. Now what are the factors which decide the starting dose of the gonadotropin? Age, baseline FSH, E2, LH, AFC, BMI, whether there is a presence of PCOS. We all know, it is very well known how the dose is decided. So starting dose, how it is to be decided? Starter dose is 150. If age is more than 37, add 75. If milder PCOS, minus 75. If PCO bad, no deduction in the dose, because ultimately we will have to increase the dose. Bad PCOS, characteristic of the bad PCOS, they are resistant to stimulate. They need higher dose of gonadotropin and very thin margin of safety. Suddenly there will be blast, multiple follicles. So you have to be very careful. Always try to bring down the basal LH level, because AMH, LH and androgens all go hand in hand. So whenever there is severe PCOS, always make sure that you start when the LH level is on lower side. That can be achieved with the progesterone or antagonist. There is a history of OHSS, you can decrease 75. If there was a previous poor response, you can increase 75, maximum 450. And endometriosis, pelvic adhesion, peritoneal disorder, you have to increase by 75. Side effects of extraordinary high dose, resistant to sites, progesterone elevation. And very important point I want to highlight. Many times all youngsters, they think that, okay, Sankara has said that if you want to increase the cumulative pregnancy, then you can start with the stimulation with the 450, 600, whatever you want. Because ultimately, you are concerned with the cumulative pregnancy out of one stimulation. But that's not correct. Why not correct? Because there are papers which says that even if there is a progesterone elevation more than 2.25 or maybe 2.5 in after the stimulation on the day of trigger, these oocytes, even if you freeze the embryos with these oocytes, they are not going to give the pregnancy. These are not normal embryos. These are aneuploid embryos. So you should have you should be little rational on increasing the dose of the gonadotropin. You should not increase the dose beyond 450. 450 is upper limit. You should not go beyond that. Because there are very high chance of progesterone elevation. There are very high chance of escape of suppression of the pituitary, so maybe premature LS surge, endometrial receptivity disturbed. Blastocyst rate is same whether you use a milder dose or higher dose. LH activity is useful in posidone group 1, 3 and 4, mainly elderly patient. In elderly patient, more than 34 years, the recombinant LH is inferior to small dose of SCG. You must understand. Small dose of SCG is better in elderly patient. This is very important. The monitoring of the stimulation. So these always should be registered in your mind. The E2 doubles in 2 days. The Play2 more than 3 days associated with the poor outcome. Mature follicle contribute 200 picogram each. The lead follicle grows 2 millimeter per day. The follicle more than 8 to 10 millimeter acquires LH receptor. The E2 continue increasing for 1 day after stopping the gonadotropin, and follicle continue to grow for 4 days after stopping the gonadotropin. Effect of gonadotropin only be judged after 4 days. See, many youngsters, they are habit. 2 दिन gonadotropin, 2 days they give gonadotropin, then call the patient and see the follicular scan. No, never do that. If you want to judge the effect of gonadotropin, you have to wait for 4 days. After 4 days only call the patient and see the effect. And if it is insufficient, you can increase the dose at that time. Follicle growth was considered to be asynchronous when one or two follicles, leading follicles were more than 4 millimeter larger than the rest of the cohort. That's the definition of the asymmetry. Now, what is the optimum stimulation? On day 6, if you get 10 to 12 millimeter follicle, it's good. You're going good job. On day 8, 14 to 16 millimeter, and on day 10, at least 3 follicles should be more than 17 millimeter. Costing, nowadays we don't do. Costing more than 3 days is not advisable. If there is a severe fall of estradiol, that's not good. Cycle cancellation on stimulation day 7. If the estradiol is found less, there is no follicle more than 10 millimeter cycle, this cycle requires to be cancelled. Trigger criteria, we follow majority of the follicle should be between 17 to 22 millimeter. If it is long agonist protocol, we can give 1 or 2 days extra. It increases the oocyte yield, but does not translate into increasing the live birth rate. Agonist trigger, when E2 is less than 4,000, dual trigger with SCG can be given. If it is more than that, then better not to give SCG. Then regarding the trigger, dual trigger is best except hyperresponder. Double trigger when there is a lesser follicle output rate or empty follicle syndrome, or I think I will quickly rush. This is very important. When we should expect suboptimal response to the trigger. So at the starting of the stimulation cycle, if the LH level was less than 1 international unit, there are 15% chances. And if it is more than 2 international unit, less than 2% chances. So it is good to measure serum LH level, especially in donor at the beginning of the cycle. On the day of trigger, it is not so important, because on the day of trigger, even if it is less than 0.5 international unit, only 5% chances. And if it is less than 0.1, 25% chances. But it rarely happens less than 0.1 on trigger day LH level. It rarely happens. So better to scrutinize at the beginning of the cycle only. Risk factors were present, use SCG at the same time only. But if there was absent, then repeat serum LH level and 12 hours after the trigger. Serum LH level, 12 hours after the trigger. So LH level on the day of trigger, if you do not measure, that's fine. But after agonist trigger, measure 12 hours after the trigger LH level. If it is less than 15, then you have to pre-trigger, do serum progesterone level, and serum progesterone doubling is not there. Then you can give SHG 1000, 10,000 unit at the 24 hours and pick up at 60 hours, 36 hours after the trigger. But if it is more than 30 LH level, then there is no extra measures are required. And if it is in between, then you have to look into a progesterone level. Progesterone prime protocol commonly used. Doses requirement is more. If you want to emergency includes, there are a lot of, Madam, can I stop? Because it's not possible to finish the presentation. I'm really sorry.
Thank you, Dr. Rajesh Kardia. You made it very concise, though it's a very, very difficult topic to concise it. We too feel your problem here. Yeah, thank you.
Thank you. Really sorry I couldn't finish my presentation, but I'm here to answer your queries regarding the protocols.